Thomas Baldrick here, Thrombosis.TV coverage of the 2015 ISTH conference in Toronto. Joined now by Dr. T.J. Milling from the Dell University of Texas Medical School. Thank you, sir. I know you just got to town. Thanks for coming by.
My pleasure. Thanks for having me.
Let's talk about this study of yours. Can you first give us a background on it?
Sure. Pradaxa, the new direct thrombin inhibitor blood thinner, has been on the market since 4 or 5 years, and the curiosity was, well, what's happening in clinical practice with major hemorrhage? I think you all know from the clinical trials that got the registration with the FDA that it was not inferior to warfarin. But outside of a clinical trial, we were curious how major hemorrhages on Pradaxa were being treated, how clinicians were attempting to reverse the blood thinner in the cases of life-threatening hemorrhage, and what some of the outcomes were.
And what is the data that you have to present?
Sure. So we reviewed over 500 charts in 5 cities and multiple hospitals, and put together a database of over 200 major hemorrhage patients. As you'd expect, about 80% of those are GI bleeds, upper and lower GI bleeds. 10% or so are intracerebral hemorrhages, intracranial hemorrhages, and then there's a smattering of epistaxis and retroperitoneal hemorrhage and that sort of thing. It was a little surprising that the intracranial hemorrhages, given this, all the limitations of a retrospective chart review kind of study, out of 36 ICHs, this is including both traumatic and spontaneous, only 2 deaths, which is much lower than you would expect with warfarin or Pradaxa.
What does this data say to you?
Well, as an emergency physician, the most interesting part for me was looking at what people were using to reverse the so-called irreversible anticoagulants, and that's a major criticism of all the NOACs, right? So the reversal agents are for the factor Xa inhibitors like rivaroxaban and apixaban and the DTI. Pradaxa are all in late-phase clinical trials, and the reversal agent for Pradaxa may be available very soon. But for the last 4 years, clinicians have kind of been left on their own to figure out what to do when a patient's bleeding to death in front of you and they're on this anticoagulant. So that to me was the most interesting thing, and it was, given the uncertainty of what to do, there was a wide variety of what was done.
Dr. Milling, what would you say physicians should do with this research?
So I think it informs us a little bit about maybe the perception of helplessness of clinicians in the face of major hemorrhage on these drugs, and very little guidance. I still think the agents we probably should use until we have a specific reversal agent are PCCs, and both activated and non-activated PCCs. And patients tend to do pretty well despite a sort of varied approach to treating them in these scenarios.
Thank you for coming by. We appreciate it.
My pleasure. Thanks for having me.